Welcome to Indian Cancer Society's NK Medical Empowerment Program session on cervical cancer and HPV vaccine. We are very grateful to the doctors of Batra Hospital and Research Center for your unstinted support and collaboration to hold this program. We also appreciate the support of the Indian Medical Association, Delhi South, President, for your alliance and participation. Indian Cancer Society was established in 1951 and is India's first NGO in the cancer space. ICS is working for cancer awareness, early detection by screening, financial support for the treatment of underprivileged patients, survivorship and rehabilitation, cancer registry and support groups. ICS has branches in Mumbai, Delhi, Bangalore, Nagpur, Kolkata, Lucknow and Patna. ICS has always been a pioneer in India, first to start population-based cancer registry, the first indexed oncology journal, comprehensive cancer care programs, the first cytology unit, chemotherapy unit, digital mammography unit, cancer insurance scheme, cancer survivorship and rehabilitation programs. Continuing in the same spirit, we are introducing the first of its kind medical empowerment program under the leadership of Dr. Anita Borges, Senior Cancer Pathologist, and she is the Vice Chairperson of Indian Cancer Society. Now, what is the need of a medical empowerment program on cancer? Well, ICS has been focusing on creating cancer awareness in the general population. There is a critical player in the ecosystem who has not been utilized to full potential. That is the general practitioners or family physicians or family doctors. They are the first point of contact and trusted doctors for most of the general population. Many of them are practicing in areas where people from underprivileged or marginalized communities are residing. Due to lack of access to oncologists and the expense involved, patients are not likely to consult a specialist unless the problem persists. The Medical Empowerment Program is designed to upgrade the counseling and clinical skills of family physicians and general practitioners on common cancers. ICS believes that the GPs or FPs could play a crucial role in the cancer space. Early detection, during treatment, and even in post-care, especially counseling, pain management, and palliative care. This project is focused on constructively improving family physicians' cancer contemporaneous and involvement, thus motivating them to help cancer suspects and taking the patients through their cancer journey from diagnosis to post-treatment and palliative care too as necessary. We plan to conduct a free online training course for family physicians on various cancers and related topics in due course and would keep all of those who have attended this session informed. We would now like to show you a video of Dr. Anita Borges, Vice Chairperson of ICS, speaking about the MEP program. This will be followed by a HPV vaccine awareness film made by ICS.
The Naveen Kshatriya Medical Empowerment Program is a new initiative of the Indian Cancer Society, which was founded in 1951 and which has been doing human service over all these years. The Indian Cancer Society does screening, awareness, finds financial help for cancer patients through their Cancer Cure Fund, is working in the area of rehabilitation and survivorship, and is also very much in the field of education and research. Now, in this field of research, there is the important cancer registry, which is the Mumbai Cancer Registry that was started as the first population-based cancer registry in this country. This is just one of several firsts that the Indian Cancer Society is known for. The Naveen Kshatriya Medical Education Program is something new. It began its life during the 2020 pandemic. during the pandemic, many of the activities of the Indian Cancer Society were shut down because of the fact that no physical contact could be made. And this was the time that a decision was made to try and reach patients as well as doctors online. Now, one of the groups that had never been addressed by the society were primary care physicians and or family physicians as we call them. Now, family physicians actually play a very important role in the lives of their cancer patients, but really were not really aware of how and what role they could play. So what the Indian Cancer Society did was to try and engage them, not by didactic lectures to be held online, but to get their attention through case capsules. And these case capsules would be like virtual panel discussions, where a patient, right from the time of diagnosis to treatment, was discussed online by a panel of doctors that included general practitioners, oncologists, all sorts of other specialists who might have been involved in the journey of that particular cancer patient. And these case capsules were shown online to groups of general practitioners, and it became very popular. By the time this got rolled out and a few such meetings were held online, the pandemic was over. And once the pandemic was over, physical meetings were possible. And we had the case capsules then shown at physical meetings, and we had oncologists meeting with general practitioners, watching this case capsule discussion, and then having a free-for-all question and answer session. And these question and answer sessions were extremely lively. They were, for the first time, general practitioners and oncologists were face-to-face, and the oncologists realized that general practitioners could play a really important role in managing small problems that their patients faced during treatment: nausea, vomiting, a little bit of pain, discomfort, etc. On the other hand, the general practitioners found their interaction with oncologists in a forum extremely interesting, because not only was the case capsule directing their attention to a particular kind of cancer, and most of the sessions were on breast cancer, they were able to have a number of their queries, their misconceptions cleared by the interaction with the oncologists. And this is now become one of the ways in which the Indian Cancer Society can spread various messages on diagnosis, messages on awareness, wherever necessary on screening. But more than anything else, the general practitioners understand that their role is important. They should not miss niggling chronic symptoms, which seem to be everyday symptoms, but yet which can ultimately lead to a diagnosis of cancer. I think that the Naveen Kshatriya Medical Education Program is just one of the programs that have been recently started. We have a long way to go, but I think the Indian Cancer Society can certainly empower general practitioners to the benefit of all their cancer patients.
अपनी बेटी की बड़ी फिक्र रहती है तुम्हें? देर शाम आंगन में बैठ के उसकी राह देखती हो, तपती गर्मी में उसकी छांव बन जाती हो, उसकी सेहत की फिक्र भी थोड़ी एक्स्ट्रा ही करती हो। उसे हर अनहोनी से सुरक्षित रखती हो। अपनी बेटी के लिए इतना कुछ करती हो तो एक चीज और भी कर लो, बेटी को दो लंबी उम्र का आशीर्वाद। अगर आपकी बेटी की उम्र 9 से 14 साल के बीच है, उसे लगवाओ HPV का टीका, ताकि भविष्य में उसे सर्वाइकल कैंसर होने की संभावना ना हो। महिलाओं को होने वाला आम कैंसर मतलब सर्वाइकल कैंसर का खतरा अब टाला जा सकता है। याद रखें, जितना जल्दी टीका उतनी ज्यादा सुरक्षा।
अधिक जानकारी पाएं indiancancersociety.org पर और रहें कैंसर से 2 कदम आगे।
We are honored to have Dr. Sudeep Raina at this first MEP session in Delhi. Dr. Raina is the Director and Senior Consultant, Surgical Oncology at Batra Cancer Center. He has fellowship in Surgical Oncology from Tata Memorial Hospital, Oncosurgical Fellow of the Ethicon Institute of Surgical Education, and Fellow to Association of Surgeons of India. Dr. Raina has performed major surgical resections with the highest success rates, and he has achieved excellent results in disease outcomes along with minimal morbidity, mortality figures. He has extensive expertise in breast, head and neck, gastrointestinal and gynecological cancer surgeries. We now invite Dr. Raina to deliver the keynote address.
Good afternoon, dear friends, colleagues, ladies and gentlemen. First of all, I'm privileged to be standing on this dais and addressing this audience. And on behalf of the Department of Oncology at Batra Cancer Center, Batra Hospital Medical Research Center, I extend my sincere thanks and gratitude. Today, as all of you are aware, we shall be having a discussion regarding cancer of the cervix. And while we shall be getting into the nuts and bolts of this disease as the session progresses over the next hour or so, there are some little interesting points regarding this disease which I thought I'd sort of share with you. Cervical cancer is a pretty ancient disease, and in fact, the first mention that we have of cervical cancer is as old as 400 BCE, 400 years before the Common Era, when Hippocrates described it as an incurable disease. Since then, obviously, we have come a long way, and I can say that for a couple of millennia, there was no major advance in the management and the detection and the treatment of this disease, till the Papanicolaou smear and the Pap test were discovered in 1928 and 1941 respectively. And in 1976, there was a major advance in the treatment of this condition when Hausen identified the human papillomavirus DNA in genital warts and cancer of the cervix cells. Subsequently, in 2006, it was the first HPV DNA which was approved by the FDA. Now, from the clinical standpoint, as an oncologist, today in India, though the rates of cervical cancer are falling dramatically in the developed countries, we still continue to face a very high burden of this disease. Though of late it has been overtaken by breast cancer as the most common cancer affecting women. But still, in terms of absolute numbers, the figures are still going up. But of course, as far as incidence is concerned, cervical cancer is now number 2. And this slight change has been probably brought about by education, awareness, and the advent of the HPV vaccination. If you look at it from the point of view of the availability of a vaccine, it's actually very sad that a disease which is 90% preventable by a simple course of vaccination is still, taking such a huge toll of society in terms of mortality, morbidity, and economic damage. Vaccination protects against multiple strains of the human papillomavirus and may prevent up to 90% of all cases of carcinoma of the cervix. The dramatic drop in the incidence of cervical cancer in developed countries shows us that this is a mountain that can be summited. It's only that we need certain, education, spread of awareness, and we also need, of course, intervention by the government, allocation of funds. But while the government is at its job and is doing what it can, we as clinicians and as doctors and oncologists, we can do our little bit and in spreading awareness regarding this condition and what can be done to prevent it. So the next time we see a young girl walking into our OPD, even if it is for an unrelated cause, I think all of us can spare at least a minute or two to just counsel them regarding the availability and the presence of a vaccine like this. Because as I'm sure it will be discussed later on, HPV vaccination can start as early as the age of 9. And the earlier that we get this vaccination done, higher are the levels of protection that are offered against this disease. So the next time any young girl comes into our OPD for any reason, one can just spare a minute or two telling her that this is available and ideally she should have this done. And also as a physician, even if you're not an oncologist, and you get to see a lady who is complaining of any form of bleeding per vagina, whether it is excessive bleeding at the time of menses, bleeding during in between periods, or it is bleeding after the cessation of menses, don't hesitate to do a per vaginal examination, a speculum examination, and in case of any doubt, send it to the nearest oncologist. These simple interventions at very early levels can actually produce huge significant changes in the results that we see. So now I shall leave this stage to my colleagues and friends, and Dr. Irfan, who will be presenting something regarding this disease, and then after that we will be available for a panel discussion. And thank you all so much and welcome here.
I invite all the panelists to please come on the stage.
Very good afternoon to all. First of all, thanks to Indian Cancer Society for giving us this opportunity to organize this first anti-medical empowerment program here at Batra Hospital. We are pleased to organize this session here. So we shall be doing a small case discussion, and after that I'll be presenting a few slides on HPV vaccine. So we should be starting with a case presentation. So a 42-year-old female of low socioeconomic status, gravida 2, para 2 with 2 live children, came with complaints of foul-smelling vaginal discharge and postpartum bleeding with no significant past and family history. On general physical examination, there were no abnormalities that were found, and on the pelvic examination, a per speculum or a per vaginal examination, there was a growth in the cervix approximately 3 into 2.5 centimeters with no involvement of fornices or parametrium. So I would like to start with I think Dr. Ritesh. Dr. Ritesh, if a patient like this comes to your OPD, so how will you proceed?
So once the pelvic examination has shown the mass region in the cervix, and of course the PVPR, everything is free, you proceed with biopsy. Once you do the biopsy, you confirm what type of histology it is. Basically, it is not coming into HCL or it's not intrathecal neoplasia. You have to prove that it is a carcinoma. Okay. Once the carcinoma is proven, then you go with investigation like either you do an MRI or a PET scan. In this case, apparently an MRI pelvis would suffice in my point of view. Okay. And once we have the staging in hand, radiological, clinical staging, then we can proceed for treatment management.
Okay. So, Dr. Nikhil, you agree or would you like to do something else?
Yeah, I would agree. We should consider for a per speculum, per vaginal guided biopsy to confirm histological diagnosis of cervical cancer. And once we have the diagnosis, we should do a MRI pelvis to see the extent of disease in the pelvis, as well as an X-ray can also be done to see for any distant mets. If it is localized disease and there is no involvement of the parametrium, we have to consider for either surgery or CTRT as per discussion with her.
Perfect. Dr. Ritesh and Dr. Nikhil had already told you that we go for a routine blood investigation, which includes a complete blood count, liver function test, a kidney function test, and of course a biopsy, which gives us a tissue diagnosis. Mostly patients with cancers of the cervix have a squamous cell carcinoma. And once we have a tissue diagnosis, we usually go with imaging. MRI is the imaging of choice for cancers of cervix because of the better visuality of soft tissues in an MRI. And do we have any preference in the investigation? Dr. Anna, if you can please tell us, do you have any preference for investigation like CT, MRI or PET scan?
I personally feel that an MRI is of course mandatory because that is going to assess the parametrium and whether the bladder and the rectum are free or not. PET scan I think is optional in a case like this. I would initially probably ask for a chest X-ray, and if the symptoms sort of suggest so, or if finance is not a major criteria, then I would actually go for a PET scan. PET scan nowadays, you feel that if you don't prescribe a PET scan and people consult somebody else, the first thing that the other person will tell you is कि तुमने अभी तक PET scan नहीं कराया. So from that point of view, I will place the option of a PET scan on the table and then leave it to the patient himself. But an MRI is mandatory.
Okay. Dr. Jha, would you like to add something to this?
I think we have scholars here who have already explained everything. Okay. No comments from myself.
So, okay. So we just concluded that we have to go for the investigations of the patient. The routine investigation would be an MRI of the pelvis, and an X-ray of the chest would suffice as a metastatic workup. I understand, as Dr. Raina said, that PET scan is into fashion nowadays, but there are certain guidelines and protocols that need to be followed. So PET scan is not required as a part of initial investigation in case of CS cervix. Of course, in the post-treatment period, we can definitely opt for a PET scan, but it can be avoided as an initial part of the investigation. So next, we all are aware of the pre-post staging of the cervical cancer. We have, broadly I would say, we have 4 stages of cancer. Stage 1 is when it's confined to the cervix. Then we have further categories of this. So stage 2 is when it extends beyond the cervix. It extends the upper third of the vagina or involves the parametria. That becomes a stage 2. And if it involves the lower third of the vagina and extends up to the pelvic wall, causing hydronephrosis or a non-functioning kidney, that becomes a stage 3. And stage 4 is when it involves the bladder and the rectum, or it goes distantly to lungs, liver, bones, or any other part of the body. So this is in broad terms I'm telling you. Of course, we have further subsets like 1A1, 1A2, 1B1, 1B2. So once the staging is done, so how should we proceed in this patient? So Dr. Ritesh, would you please tell us how do you proceed for the same patient? It would be 1B1, it would be a stage 1B1 disease. The one we discussed, it was involving only the cervix, approximately 3 centimeters in size, not involving the parametria. So how do you proceed with this patient?
1B1, I think I would place the option of surgery also for this patient, because apparently in this there is very less involvement of nodes as per the staging, as per the data available. So this patient would be a suitable candidate for surgery.
Right.
That's first option which I would use.
Dr. Anna?
Age and
42 years old, approximately 42 years old. And if it would have been 55 years, then still surgery. Dr. Nikhil, you want to add something?
So young female early stage cancer, I think surgery should be the treatment of choice in this patient.
So in early stages of the cancers of the cervix, surgery is the preferred modality, especially in stage 1A and 1B1. Surgery is preferred. Anything beyond 1B2 and onwards, we usually see patients in stage 2 and 3 in our day-to-day practices. So in those cases, it's the concurrent chemoradiotherapy that is the treatment of choice. But in very early stage cases, like I told you, 1A and 1B1, up to 1B1, surgery is the treatment of choice, and depending on the histopathological report, once the surgery is done and we have a HPV report in our hand, that can also guide us, if the patient needs some further treatment or not. So surgery for very early stage diseases, and for later stage we have the concurrent chemoradiotherapy, that is the treatment of choice. I would like to ask Dr. Suman Niranjan, can you ma'am share any of your experience? I understand you may not be directly getting the cervical cancer patient, but just want to know your experience if you have come across any cervical cancer patients, please share with us.
Because as we all know, homeopathy is the alternative treatment. It's in chemotherapy cases with the side effects, with the other symptoms, we can manage to give the homeopathic medicine in these cases, and 10-12 sessions होते हैं chemo के, तो उसमें we can give the homeopathic medicine before chemo and after chemo, and all the parameters we can maintain with these medicines, and the symptoms like nausea, vomiting and other discomfort we can manage with these homeopathic medicines.
Thank you. So what is the cervical cancer burden in India? So as Dr. Anna earlier told us that it's the second most common cancer in India. Approximately 123,907 new cases with approximately 77,000 deaths every year because of the cervical cancer, and approximately 365.7 million women above 15 years of age are at risk of developing cervical cancer. The incidence rises in 30 to 34 years of age and peaks at 55 to 65 years with a median age of 38 years. And at any given time, about 6.6% of women in the general population are estimated to harbor the cervical HPV infection. So let's come to the common causes of cervical cancer. So all of us are aware about these commonest causes of cervical cancer: HPV, human papillomavirus, serotype 16 and 18. These are the commonest causes of cervical cancer and are responsible for causing 76.7% of cervical cancers in India. So this is huge. So if we remove HPV infection, 76% of our job is done. So long-term use of hormonal contraceptives, these are the other risk factors for causing cervical cancer: high fertility, early initiation of sexual activity, multiple sexual partners, tobacco smoking, co-infection with HIV, co-infection with chlamydia, herpes simplex, immunosuppression, low socioeconomic status, and poor hygiene and diet, low in antioxidants are other co-factors that are responsible for causing cancers of the cervix. So I just wanted, this is an interesting slide. If you see, this is a slide showing educational status of women diagnosed with cervical cancer. So if you see in this slide, the chances of having a cervical cancer is 38.8% in women who are illiterate, and those who are well educated, the chances of having cervical cancer is only 2%. And if we look at the clinical extent of the diagnosis, in majority of the scenarios, we see patients who are in the local regional, patients have a disease in the cervix and is gone into the, we usually see patients in stage 2, 3 and even in 4A stages. So what is this HPV and what are the diseases it can cause? So HPV is a human papillomavirus, is a sexually transmitted pathogen, and it causes anogenital and oropharyngeal diseases in males and females. It's not only causing cervical cancer but causes other cancers as well. So persistent viral infection with high-risk HPV genotypes cause virtually all cancers of the cervix. So I told you HPV 16 and 18 are responsible for causing 70% of the cervical cancers, and there are additional types like 31, 33, 45 and 52 which cause the rest of the 20% of the cervical cancers. So Dr. Jha, can you please tell us, do we have any means to prevent and diagnose this cervical cancer early?
So basically our role here comes here when it's so easily available and it's so easily preventable. So our role is to encourage all our patients to get this vaccine. Say, as Dr. Anna was saying, that we can start our vaccination for patients, for children as low as from 9 years of age. More so if there's a history of some, say, assault or some sort of abuse in such patients. Otherwise, from 11 to 12, we should encourage patients to have HPV vaccination, both in males as well as females. And from there, say from 13 to 26, it should be mandatory for the persons to get, the children to get vaccinated. And we can continue in case the person is not previously immunized to get these vaccination up to the age of 45 years. That's recommended. So basically, this is what we all should do, that encourage our patients to get themselves vaccinated so that we can decrease the disease burden of as the second most common cancer in the society.
Very, very rightly said. So vaccination definitely number one, and then screening and early diagnosis and early treatment is the key. So I'll just briefly tell you about the cervical cancer screening recommendations for women who are at average risk. Cervical cancer screening should start at age of 21 years, and Pap smear should be done every 3 years between 21 to 29 years of age, and Pap test and HPV co-testing every 5 years between 30 and 65, or if only a Pap test is done, then it can be done every 3 years. So these are the recommendations for screening of cancers of the cervix. This is a graph, showing a girl, a person getting an HPV infection approximately around 15 years of age. Then as the age progresses, she may get pre-cancer stage of the cancer, maybe around 25 to 30 years of age, and an invasive cancer or with symptoms, it would be around when the child is around when this person is around 35 to 40 years of age. So we have approximately 15 years of a window period during which we can act. So the first thing is primary prevention, in which we can do vaccination. So HPV vaccination is recommended for girls 9 to 14 years of age. And secondary prevention is when we do the screening in women greater than 30 years of age, or an equivalent test. So you must have heard of visual inspection with acetic acid. So that is also one of the screening tests that's done especially in our settings. VIA is done. So I'll just show you a slide. This is from Ministry of Health and Family Welfare, Government of India. This is showing the screening and management algorithm for cervical cancers. So in this, we have the visual examination using the acetic acid. So anybody who is VIA negative, so then we can repeat a VIA after 5 years. And if somebody is VIA positive, you have to refer to a gynecologist. And then we have to see if the patient is eligible for cryotherapy. And if yes, patient has to undergo cryotherapy. And if not, then a biopsy has to be taken. And once a biopsy is taken, we can have 3 scenarios. A patient can have a low-grade CIN1. Patient will go for cryotherapy. If it's a high-grade CIN2 or 3, then we can go for a loop or lead. And then if it's an invasive cancer, the doctor has to refer to a higher center or a tertiary care center. So this is an algorithm that has been provided by Ministry of Health and Family Welfare for general physicians, for people who are working at in the rural areas or in dispensaries or at primary health centers. So this is the algorithm that needs to be followed. This is a 90-70-90 protocol for global elimination of cancer of the cervix. So according to this protocol, if 90% of girls are fully vaccinated with HPV vaccine by the age of 15 years, 70% of women are screened with a high performance test by 35 years of age and again by 45 years of age, and 90% of women identified with cervical disease receive treatment. 90% of women with pre-cancers are treated and 90% with invasive cancer are managed. Then this can lead to global elimination of carcinoma of the cervix. So this is called as 90-70-90 protocol. So what are the vaccines available to prevent cervical cancer? If so, when and how to give these vaccines? Dr. Nikhil, can you just briefly tell us about the vaccines?
So there is a bivalent vaccine by the name of Cervarix, which is active against HPV 16 and 18. It is recommended for girls from age of 9 years till the age of 45 years. although the efficacy is better in younger females from 9 to 15 years of age. And there's a quadrivalent vaccine by the name of Gardasil, which is against HPV 6, 11, 16 and 18. And there's a new nonavalent vaccine, Gardasil 9. And recently there is an Indian vaccine which has been launched by the Serum Institute of India in January 2024 by the name of Cervavac. So again, it is a quadrivalent vaccine against strains of 6, 11, 16 and 18, recommended for both boys and girls.
Yeah, very rightly said. So I'll just show you the slide for the audience. So you can see we have a quadrivalent vaccine which targets HPV 6, 11, 16 and 18, and a nanovalent vaccine by the name of Gardasil, which in addition to these 4 strains, this also targets 31, 33, 45, 52 and 58. Then we have a bivalent vaccine which targets just 16 and 18. So as Dr. Nikhil rightly said that we have a vaccine by the name of Cervavac, which is a quadrivalent human papilloma virus vaccine which has been developed by Serum Institute of India. So these are the vaccines available. Cervarix, this I think GSK, this is a GSK product. And then we have Gardasil 9, this is from Merck, and Cervavac is from the Serum Institute of India. So these are the vaccines available with us. So what's the route of administration? So it's an intramuscular injection. It must not be injected intravascularly or subcutaneously or intradermally. So the recommendation is between 9 to 14 years of age, 2 doses of HPV vaccine have to be given at 0 and at 6 to 12 months. So if somebody gets a vaccine today, after 6 months, the girl will receive another shot of vaccine. And for 15 years of age or older, 3 doses of HPV vaccine are recommended at 0, 1 and then 6 months. So 0 at, for example, a girl gets a vaccine today, then she gets after 1 or 2 months, and then she gets after 6 months. So this is for girls who are 15 years or above. For girls who are just 9 to 14 years of age, 2 shots are sufficient. So missed dose can be resumed without restarting the series. Post-vaccination instructions: once the vaccine is given, there has to be a 15-minute waiting period in a sitting or spine position. Unnecessary evaluation is not required. And let's come to the side effects of vaccine and if it's safe. You know, when vaccination was started, one of my colleagues shared a very interesting slide. In 2009, I think the vaccination drive was started as a pilot project in Gujarat and Andhra Pradesh, in some districts of Gujarat and Andhra Pradesh. But it was seen that around 7 deaths happened after the vaccination. So it came to a halt, that no vaccinations were given later on. But then there was a survey that was done that why these 7 deaths happened. It was found that it was unrelated to HPV vaccination. So 2 girls died of malaria, 1 died of typhoid, 1 had some, 1 died of suicide because of some psychological issues. So they were not related to HPV vaccination. So it was a myth that, because of the HPV vaccination, 7 girls had died. So, but still there are some side effects which I would like to share with you. So there's pain, redness or swelling in the arm where the shot is given. Some patients may get fever, dizziness or fainting. This is a very common side effect, and that's why a 15 minutes waiting period is recommended once the shot is given. Some patients may get some headache or nausea, muscle pains, and to prevent fainting and injuries, adolescents should be seated or lying down during vaccination for 15 minutes after getting the shot. Very rarely anaphylactic reactions happen. That can happen with any other vaccination as well. So the myths regarding HPV vaccination need to be cleared and should be discussed in detail with patients. And what about vaccine to special population? Pregnant or breastfeeding, it's not recommended. For lactating females, lactating females can get a shot of HPV vaccine. If there's a pre-existing HPV associated disease, vaccination is still recommended. Now this is interesting, Dr. Anna, this is for healthcare workers at risk for occupational exposure. So American Society for Colposcopy says that vaccination is recommended for healthcare workers who are routinely exposed during the surgeries. This includes gynecologists, dermatologists, So I think you should get a shot before you enter the theatre on Monday.
That's true, but I'm more than 45 years old, so so I don't think it'll work for me.
Okay. So patients with HIV or immunocompromised conditions, again 3 doses at 0, 1 to 2, and then 6 months is recommended for all immunocompromised patients through 26 years of age. Should boys be vaccinated? Yes, the answer is yes. The boys have to be vaccinated because cervical, the HPV virus is not gender biased. It can affect males as well as females. HPV vaccine is recommended for boys, because it can prevent from anal cancers, from throat cancers, from genital warts, from penile cancers. So definitely it's recommended for boys as well. But in boys, it's the nanovalent vaccine that's recommended because then the strains that are responsible for causing these types of the cancers are not present in the quadrivalent vaccine. So that's why nanovalent vaccine is recommended for boys. So HPV I told you is recommended for boys between 9 and 14. 2 doses, same as for girls if less than 15 years of age, and 3 doses if greater than 15 years of age. So it offers protection against HPV-related cancers of the penis, anus, and oropharynx. And in India, only the HPV-9 vaccine is licensed in males. And why is it essential to start schedule at 9 to 10 years and not later? Because young adolescents mount a superior immune response compared to older individuals. And of course, prevention is better if started earlier. And if we start less than 15 years of age, only 2 doses are recommended. And vaccination should be given before being sexually active. And if you look at this slide, it's very interesting. Percentage of 15-year-old who have had sexual intercourse, 2.7% in men and 8% in women. So it should be preferably given before 15 years of age. So how effective is HPV vaccine? Yes, it's very effective because seroconversion rates of 93 to 100% in females and 99 to 100% in males. HPV vaccination is effective in preventing cervical cancers, vaginal, vulvar, intrathecal lesions, and it's greater in those who do not have prior HPV infection. In India, bivalent vaccine and quadrivalent vaccine is expected to prevent 83% of cervical cancers, whereas a nanovalent vaccine is expected to prevent 98% of cervical cancers. So, do we have any vaccination program in our country? Aiming for Viksit Bharat by 2047 and with a sharp focus on providing momentum to Nari Shakti, Union Minister of Finance and Corporate Affairs Srimati Nirmala Sitharaman proposed vaccination to prevent cervical cancer as she presented the interim budget in 2024-25 in Parliament on Feb 2024. And it was recommended to be included in universal immunization program. And 68 million girls in India should have been vaccinated against HPV, and further 11.2 million girls aged 9 years will subsequently be targeted for routine HPV vaccination each year. This is a proposal. This has not been included as yet because if you check the universal immunization program now, it won't show you the HPV vaccine, but it's a recommendation that should be included in the universal immunization program. So there are other government's initiatives in promoting the cervical vaccines in India. So inclusion of universal immunization program, development of indigenous vaccine, budgetary allocations, school-based vaccination drives, community outreach programs, then digital platforms, technical assistance, community mobilization, and research and development. A recent study found that one of the most popular articles posted on social media in 2018 and 19 on 4 most common cancers, 1 in every 3 contained false, inaccurate or misleading information. So we need to discuss this. Most of that misinformation about cancer was potentially harmful. So Dr. Ritesh, can you throw some light on this? The misinformation that patients have. I think we face these problems in our day-to-day practices. Patients having so many myths about cancer, about cervical cancer and other things. So how can we keep this misinformation on check? What can we do about it?
See, in clinical practice, whenever the patients come, they always say that so and so patient had this, and we read that in the paper. But sometimes whatever comes on the paper, even in the newspapers, there are selective reports, early reports, which may turn on opposite side later on. So it is for the consultant and the family physician or the physicians involved to make them understand that even if there are studies which are upcoming, but still they may not be suitable for a larger population. After the statistics has revealed in the long run, they may not be suitable for us. So they don't need to, keep their hopes on that very study. And these sort of articles and everything will be seen on social media. Now there is no check on social media. You can't prevent this, but once the patient lands up into your OPD or your consultation or with the family workers, with the the ASHA workers or the people who are involved in healthcare, they should be able to convince them. It is the convincing power of the person who is healthcare worker. He has to convince that these are anecdotal reports or maybe false reports. What we are going to treat you is the standard guidelines and gold standard guidelines, which would give you the maximal cure rates, which has been availed through series of research and proper material. Otherwise, because they will go, okay, we'll take cannabis oil, we will take some wheat grass, but eventually they'll land up into trouble. Sometimes they go to Babaji in Dehradun or whatever, so they say, finally they are giving steroids, so we don't know what they are giving, but eventually they may end up later on in a very bad position. We have to explain. It is only the healthcare workers can make them understand. Otherwise, other people, social media is very rampant. We can't prevent things coming on social media.
Dr. Jha, can you please, tell us briefly the role of a family physician or any other specialty, with regards to vaccination screening and early diagnosis?
See, as primary care physicians are concerned, what we feel that our role comes here as far as vaccination, as we mentioned, we were discussing, that ensuring maximum vaccination in our young population, I mean HPV vaccination. So that's one thing. The other thing, as the very important thing here, especially for females, as you and Dr. Irfan, you were mentioning that we have, say, in the guidelines for pap smear examination. So whenever we are getting young females in our OPDs, maybe for totally unrelated complaints, we may encourage them to get their pap smears done with the guidelines, as you were mentioning, every 3 years from 21 to 29. Thereafter, say, every 5 years, if the HPV is also done, or every 3 years we can continue. Say this can be discontinued till around, say, I think it's 65. So this thing we can ensure whenever we are seeing patients in our OPD, at least if not ensure, we can encourage our female patients to get their routine pap smear examinations done. And the third thing I would like to mention here, that in case we get to see patients who have, say, post-menopausal bleeding, or they have mid-cycle bleeding or excessive bleeding, we need to refer them to gynecologist first, and in case we find that we are suspecting, we have a high index of suspicion for malignancy, then maybe an oncologist or an oncosurgeon. And we should have a high index of suspicion for such for the cervical cancer. And by ensuring the, say, first vaccination, second routine pap smear examination, and third gynecological examination in case there is not a regular bleeding or a post-menopausal bleeding. So by these three measures, we can ensure and help in the prevention of cervical cancer.
Yeah, thanks, Doctor. So,
I'd just like to add one thing here. While we move toward this target of immunization, universal immunization against HPV, as I said, these are processes that is part of the government. It will take some time, and even the spread of this vaccination is going to take time. But what we can do in the intervening period also, and which also progresses side by side, is education regarding sexual hygiene. See, with changing societal modes and changing, the way society is changing, all of us have noticed an increased incidence in sexual promiscuity, as well as increased incidence of smoking amongst women. And all of us know that smoking, women who have been smoking, have been shown to have much higher incidence of HPV, infections. And the easy availability of oral contraception has in a way moved people away from barrier methods of contraception. And barrier methods of contraception also need to be brought into the forefront, because not only does it prevent pregnancy, unwanted pregnancies, it also is something which will prevent illnesses like this. So I think a push towards more use of barrier methods of contraception, both for men as well as women, and an insistence, especially amongst women, that if there is any sort of sexual activity with somebody who is not a regular partner, they insist on barrier contraception. And I think that is the norm which is followed in the West, and that has translated it into dramatically low rates of cervical cancer now. So an insistence on barrier methods of contraception, and counseling women that smoking is not bad just for men, it's bad for women as well, and not just causes lung cancer and heart attack, it causes, it can play a role in the causing of cervical cancer as well.
I have a couple of questions, please bear with me. You talked about the WHO recommendation 70, 90, 70.
Yes,
The 90, which was of screening, you said high quality screening material.
right.
Then why are we still talking of HIV? Question number one. Why?
We are still talking about
HIV. Sorry.
VI.
I beg your pardon.
Visual inspection, yeah.
Visual inspection with acetic acid or with liquid iodine. Why are we still talking about it and saying it's the cheapest form? I think women deserve better. Okay, that's one question I want answered. The second thing, Dr. Raina, is when you said that using barrier contraception, to my understanding, HPV is spread not necessarily with penetrative sex. It is skin-to-skin contact. Why are we not talking about that? I think every family physician, every counselor in schools needs to be talking to young women about it. They think as long as there is no penetrative sex, they're safe. To my mind, they're not.
Ma'am, I would like to answer your first question, and second question I think the final will answer. As far as the screening methods are concerned, there are certain criteria for having a good screening test. It has to be cheap, easily available, and then it has to be the government initiative what screening test they will choose for their population. So I think visual inspection by acetic acid is a cheaper method compared to a pap test. Maybe that's the reason, that's why the family and welfare has kept visual inspection. I think that's the answer to that question. And as far as your second question goes regarding the transmission of HPV, I think it's actually transmitted and through blood. As far as skin-to-skin contact is concerned, I'm not really very sure.
I think, yes, genital warts probably, warts on the vulva and all. I'm not 100% sure about cervical cancer per se. Would just simple, skin contact lead to, with an infected male, for example, would it lead to, a chance of developing cervical cancer in a woman? I don't think that's very likely. Yes, warts, certainly yes. And I won't be 100% sure about that.
Could you find out, please, Dr.
We can
Certainly, ma'am. Certainly, ma'am.
We teach children that
Yeah.
it is skin-to-skin contact, and I'm talking of genital skin-to-skin contact.
Yeah.
Does spread HPV.
Yes, I'm not denying that. I'm saying HPV infections can spread, for example, as in genital warts. We are talking about cervical cancer, reaching the cervix is almost 5 centimeters, 6 centimeters inside. So does this skin-to-skin contact actually infect the cervix? I'm not very sure about that. Genital warts, yes. Cervical cancer, I don't know. I'll have to check. But it's an interesting point that you raised. I'll definitely look into that and get back to you on this.
I would like to add that specifically cervical cancer starts at the transformation zone. So transformation zone is between the original spermocolumnar junction and the transformed spermocolumnar junction where the HPV infection actually happens. So I don't feel and I don't believe that skin to skin contact can actually lead to HPV transmission without any sexual intercourse.
We have Dr. Vasundhara here from our department. She wants to add some point here.
Actually, ma'am, there are various strains of HPV. So the one which causes genital wart, it's actually HPV 6 and 11, while the one which is responsible for cervical cancer, it's 16 and 18. So even if a person gets HPV, that's what you were saying in a scenario, even if a person gets HPV 6 or 11 by touching a person who is having genital warts, so he can develop genital warts in future, but not cervical cancer. That's what I think everybody of us are trying to say.
So while 16-18 will not spread by skin to skin contact.
Ma'am, if one person is having one strain and the other person touches him, the second person will be getting the strain which the source is carrying, right? If I'm carrying HPV 16 and if you are touching me, you will be getting HPV 16, not HPV 6 or 11 or something like that. The strains are different and one strain does not get converted to the other. And different strains are responsible for different diseases. That's what
So according to you, 16 and 18 can only spread by the penetrative sex only.
Yes, ma'am. But ma'am, I think your point is very valid. Even for genital warts, for other strains of HPV, skin to skin contact can it can transmit the genital warts. So definitely, as far as the education is concerned, that can also be taken into consideration. So one last question: what is the psychological impact of the disease on the patient's partner and the family? So, Dr. Nikhil, would you like to take this question? Psychological impact of the disease on patients' partner?
I think there is a social stigma attached to it. Majority of these patients have menorrhagia or metrorrhagia or discharge per vaginum, and they don't tell their family, and when the symptoms are beyond control, then they consult an gynecologist or an oncologist when the patient has already advanced disease. So I think it is important to educate females that whenever these symptoms are there, immediately they should consult a gynecologist so that earlier the diagnosis, better will be the cure rates.
Dr. Ritesh? Yeah.
Actually, as Dr. Alka is also here, so I feel that the Indian Academy of Pediatrics, they also come in our South IMA branch. So they should be also, all of them, most of them should be, because they are seeing kids every day who are 8, 9, 10 years old, and on this zone where they are about to turn 9. And since we already know now that the vaccine has to be given to prevent this, so in each OPD or with every immunization card, or they should have some method to tell the family. Of course, every time the patient comes, they can tell the family, and on the card they should note that yes, this vaccine is available, and this year, at this point of your age, you should come and get vaccinated, both for boys and girls. Because initially when this came, I was not aware of boys. One patient called me up, I said it's not available for boys, but then I realized that it is available for boys. So in general, when you say CA cervix, HPV vaccination, you are fine with, okay, yes, girls have to do it. But for boys also, because it is prevention in both ways. So I think that there's a group of physicians, Indian Academy of Pediatrics, who can be a big pillar in this immunization.
I want to know whether the Cervical Vaccine Serum Institute has been rolled out in the market or not.
I am not very sure.
It's been rolled out. It's there in Medanta.
It's available?
It's available in Medanta.
Medanta, but at a much lower cost, the same 200
It's
to
available
400.
for 1800 at the moment, but the government is subsidizing it. Cervical vaccine, government of India is subsidizing it. Right now, it's been available for 200 rupees even in rural areas, but in PHCs. But in general, in Delhi, it's around 1600 to 1800 rupees in general market. Also regarding the VIA, actually, India, we have so much, 365 million women population at the moment, and to have a high definitive examination for all the patients as a screening mode, because most of the healthcare is subsidized by government of India. So it's financially not possible and physically not possible, and we don't have enough medical care workers, healthcare workers in rural India, and all of them are mostly concentrated in urban areas. but our focus should be in rural areas. And with VAA, even the ASHA workers can examine the patient and they can refer the patient to higher centers if they find some evidence of disease or any mucosal changes. So that's why Indian government has recommended VAA instead of DNA testing or pap testing. It's not feasible physically in India.
And maybe if the infection is found out, then advanced testing.
Yeah, definitely. We have the protocol for that accordingly.
Thank you, audience, for patient hearing. So, any questions to the panel? We'll be happy to take questions from the audience.
This one little thing that I wanted to tell, ma'am, regarding you mentioned about screening programs. Screening programs are actually they're a two-edged sword, in the sense that the actual benefits, one is not very sure about that as well. Take mammography for example. It's pretty much mandatory in the Western world, and now they've realized that screening mammography does not actually make any difference to cure rates. And because it's such an emotive issue amongst women, no government has the guts to actually withdraw mammography. So you don't want to get stuck in a trap like that, especially in a country like India, where resources are still relatively sparse. Of course, we are doing much better now, but the resources are still relatively sparse. So if you get into this thing of screening everybody, you might just find out that there is no real change in the cure rates, and the expenses involved are really enormous, and they could have been better utilized probably in vaccination or elsewhere or in treatment. So screening is something, well, I think it should be very targeted. It should not be random. One should actually select, if you want to say like screen sex workers or any particular subgroup, that probably makes a lot of sense. But a general screening of everybody, I am not very sure about that.
I have a comeback on that. The screening tests are probably the only time most people get to a doctor. Okay? Whether it is, sorry guys, I'll say that again. Okay. The screening test is the only time that most people get to a doctor. We have been doing, from the Indian Cancer Society, screening across Delhi and NCR. We wanted to do population screening, but it's very, very difficult getting all the preliminary work done and then selecting your population for screening. So we screen everybody, but we don't waste our resources. We don't give mammography to every woman, and neither does she want it. Our gynecologist does a clinical breast examination, which I think is the gold standard. Yes, yes. And we only give the mammography to women who have a family history, or there are some other signs which the gynecologist identifies. With the cervical screening, as I said, I believe that women deserve better. We raise the money. We go around with a begging bowl. Our hands are always out. To people who can support us to provide the pap test. We also give the HPV DNA test as a co-test where it is required. Not everybody. We can't afford it and it's not necessary. But where it is required, it is there and it's available. We also then have a colposcopy camp where a gynecologist examines the lesion and, if necessary, does a thermal ablation. Then, if anyone is found still positive, we bring them to the hospitals. You're aware of our Cancer Sahyog program. Our volunteers come to you. I think Batra Hospital has had the most amount of money disbursed from us.
So we have the poorest patient.
I think it is because you are the most proactive of them, which is what I applaud. That you should applaud that. Batra is one of the most proactive of hospitals.
Thanks for the comments, ma'am.
So we bring our...
Batra Hospital consultants are the
I know Irfan is. All the rest of you I know by name. Sudeep, I know you too. And just to remind you, you're on our medical consultancy. So what I'm saying is that when we talk of screening, there is screening which just does a naam ka vaste thing and pushes off. And there's screening like what we do when no patient is left behind. And I think for that you need to applaud us.
If we have no more questions from the audience, then I think we can wind up and yeah, please, ma'am.
There is mention of girls' age for HPV vaccine.
Yeah.
26, 45. What about the same vaccine for men? Is there any age limit?
No, I think the recommendations that were given was between 9 to 14 and then 15 to 26 only. Not sure if older men have any recommendation. Only for special things like I said about
the efficacy of the vaccination to 46 years old. We have heard in number of webinars that up to 26 there is about 70-80% efficacy, but beyond that, when they have already born the children and all, the efficacy of the vaccination, I don't know if anyone can advise us.
Sexual exposure increases. Vaccine will prevent that infection. It's not that it's going to cure an infection which is already present. So once you get older and like beyond 26 or whatever, generally the HPV infection हो गया होगा, ठीक है? So by that time, obviously, once you're already infected, having the vaccination then is not going to prevent the strain that is already there. It might prevent some new strains coming in, but the one which is already there is already there. Of course, the efficacy will not be there. And then one little rider, pap smears also have a 50% false negative rate.
We want to vaccinate before they are sexually active.
Yes, that is the idea. And there you have to break a psychological barrier also, because I have on occasion I have spoken to people about it, and वो चौंक जाते हैं कि नहीं मेरी बच्ची तो अभी 12 साल की है, 13 साल की है. So they think it's like you are trying to suggest something which is not right. So they have to get out of that mindset.
That's a very big challenge actually.
Yeah. नहीं हमारी बच्ची तो ऐसी नहीं है. What do you mean by ऐसी नहीं?
But also a message for the doctors, pediatricians particularly, gynecologists also, but all of you. Please don't say you might want to give your daughter a vaccine. You say do it. It's a matter of life and death. Just do it.
That's it.
If it's included in the universal immunization program, then definitely it makes a lot of sense.
Why should we wait?
But
How
before
many,
that, obviously,
how many
before it-
women need to die?
Right.
If I'm not mistaken, Bill Gates was there this last month.
Yes, he talked about research. He talked about research and I was very mad at him. He talked about research. We don't want research, we want action.
No, I think he was there to discuss with the Prime Minister regarding some sort of funding for the universal immunization program for cervical cancer.
Another way of spreading awareness is that people who have already got their children vaccinated, if they are brought into the field and told that you should, spread this word, coming from another mother to another mother, I think it will have more effect. For example,
in this matter, it's the PTAs which should be doing this.
Even ma'am, like 9 to 10 years is like child is in 5th or 6th class. School में होगा. Because the perfect time, the best time as per the guidelines, as per the IAP guidelines also is 9 to 10 years. But the best immunomodulation response for after giving the vaccine. And once a kid in vaccine, once a child, they will talk amongst themselves. They say मैंने vaccine ले लिया. तो कहीं ना कहीं वो एक बार वो स्कूल में तो spread होगा ही होगा.
No, but our point is that the PTA should take it up, the Parent Teachers Association.
Yeah, no, absolutely.
The schools
Absolutely.
I would like to thank the panelists, Dr. Raina, Dr. Dhienja, Dr. Maniranjan, Dr. Nikhil Antani, Dr. Tej Sharma for their valuable time. Thank you so much, sir. Thank you. I would like to hand over to Ghana Tiwari. Thank you.
Thank you, Dr. Irfan.
Big thank you to all the doctors here. We now invite Dr. Alka Malhotra, President, Indian Medical Association, Delhi South Branch, to share her thoughts about the MD. Dr. Malhotra is a practicing obstetrician and gynecologist with 33 years experience. She is an alumnus of MGM Medical College Indore. Her areas of interest are infertility and high-risk pregnancy. She has served the IMA South Branch at various posts for the last 20 years, and she is the current president of the branch. Welcome, ma'am.
Good afternoon. First of all, I must thank all the panelists for this exhaustive discussion and also the audience for the patient hearing. And kudos to the Indian Cancer Society for this medical empowerment program to discuss cervical cancer and HPV vaccination. The aim of this brilliant program today to upgrade the counseling and clinical skills of family physicians and general practitioners and also paramedics who play a crucial role in the cancer space in terms of early detection, during treatment, post-treatment care, counseling, pain management, and the palliative care. Such a program, I'm sure, will definitely help in constructively improving family physicians' cancer contemporaneous and involvement. Today, the focus is on empowering family physicians to play a stronger role. In an era where there are rapid advances in the medical science, the importance of addressing prevalent health issues cannot be overstated. So the objective of shedding light on HPV diseases and their prevention is commendable. In a world where health disparities persist, as we were already discussing, the dissemination of knowledge remains an essential tool in promoting equality and improving health outcomes. Goal of ICS organizing such a program is commendable, and this program today stands as a testament to their unwavering commitments. The objective is to eliminate cervical cancer as a public health problem in India on a priority basis. So the commitment should be to fight cervical cancer univocally, and the role of HPV vaccination and screening for prevention of cervical cancer in Indian women, irrespective of caste, religion, economic status, and educational status. The privileged and the well-to-do women have screening programs where they go for regular medical checkups, but the poor are left out. So we must look into that, which is more important. The collaboration of FOXI, American Cancer Society, and the Cancer Society of India is praiseworthy. I congratulate the ICS for their significant and determined commitment towards women's health and having programs like Cancer Jagriti, use of radio channels, faculty development programs, India Cancer Society app, mobile screening, and also the programs for the emotional support of patients and the healing and the rehab centers. FOXI is also conducting similar programs on Zoom for all its members, though it's still in the very preliminary stage. Those who attend these programs, at least 80% of the sessions people who are attending are evaluated on the basis of test questionnaires, and on successful completion of that will be given FOXI certified Mahila Kavach Kendra Master Trainer certificates, which they will be able to display in their clinics. These will be comprehensive, geotagged, in-clinic vaccination centers for women. So this is a great step taken by FOXI. For HPV vaccination training project, the 5 zones have been created pan-India. North Zone, South Zone, East Zone, West Zone 1 and 2, and Delhi comes in the North Zone. Cervical cancer is mainly caused by HPV, which is the second most common cancer in Indian women and the mortality rate of cervical cancer in India is more than 70%. So this has a substantial impact on the women of the reproductive age 24 to 45 years. By vaccinating our female population, we are significantly able to reduce the risk of developing many cancers caused by HPV, including cervical cancer. HPV vaccine has been demonstrated to have an efficacy of more than 98%. So its benefits have the potential to help protect numerous lives from many HPV-related cancers each year. We have to disseminate important information that's both relevant and vital. This includes the role of vaccines in HPV prevention, guidance on screening and early detection, empowering healthcare providers to offer the best care to their patients, and ultimately, the aim is to enable healthcare professionals, policymakers, general public with the knowledge about HPV and its vaccination so that they can make informed decisions, promote preventive measures, and ultimately save lives. This virus is responsible for a spectrum of diseases beyond cervical cancer in women and includes vulvar, vaginal, anal, and oropharyngeal cancers, and also affects men with consequences ranging from genital warts and various types of male cancers, oropharyngeal, anal, and penile cancers. The burden of these diseases is a reminder of the urgency in understanding HPV and preventing its spread. The Ayushman Bharat medical insurance of the Government of India provides for the treatment of cancers. So it's of great importance to educate general practitioners about this facility to dispel the stress of lack of funds for treatment in their patients. The word cancer instills a fear among everyone, the patient as well as the family, hence the importance of counseling. I hope that these educative series serve as a catalyst for a greater awareness and actions in the fight against HPV diseases. So let us continue to educate, vaccinate, and advocate for a world where these diseases are rare and preventable. Together, we all can make a difference. Thank you.
We invite Mrs. Josna Govind, Chairperson of Indian Cancer Society, Delhi, to share her views. She has been instrumental in ICS Delhi's journey in the service of cancer since 1985. She is also a member of the National Managing Committee of ICS. Mrs. Govind is the former Vice Chairman and Honorary Secretary of Indraprastha Cancer Society, parent of Rajiv Gandhi Cancer Institute, where she also served as a member of the Review Board and Ethics Committee for 12 years. Mrs. Govind is a founder member of APAC HPV Consultation. She represents India on the board.
If you all don't mind, I won't go up on the stage. As you can see, I'm pretty lame. So my first thanks to all the nurses who have come and filled up the seats. It's nice to have an audience, even if it is not quite the audience that we had envisaged. My next thanks are to all the doctors of Batra Hospital, particularly Dr. Irfan, for all the hard work that has been put in. I think they deserve a very big hand. In talking about this program, has anyone wondered why it is called NK Medical Empowerment Program? NK are the initials of our former trustee, Naveen Kshatriya. He parachuted in from the commercial world to come to Indian Cancer Society, and he really dived into it and learned a lot about it. He was abrasive, he was pushing, but he really made everybody sit up and start thinking of new ways of doing things. I think that it is in the fitness of things that this empowerment program is named after him. he certainly empowered ICS. So I'd like to pay my homage to the man. He died last October. He was one of the first people that we know of who went off to the US for CAR-T treatment. It didn't work. He was getting all kinds of blood transfusions, platelet transfusions every 15 days. And it was really sad to see him. So anyway, let's come back to the empowerment. When Dhana talked to us about Indian Cancer Society programs, she neglected to mention what they did. So I'm going to say that for her, and I hope that this message goes out to all of you. We took on the time of COVID as an opportunity. Suddenly, all of us Buddhis learned how to use the internet. We learned how to film people, thanks to little girls like Priya Tiwari, Vaishali, who made films. And I thank all the doctors. I think we had about 25 to 30 doctors, more than 30 doctors. We created a program which was e-learning in cancer fundamentals. We offered it to the government of India, who accepted it very happily, but didn't give us a paisa for it. So we said, okay, we'll raise the money. So if you go on to Swayam, which is the self-learning program, please look for us. Almost 18,000 people across the country have accessed it. Many of them are doctors themselves. They have been very impressed with the tutorials that our oncologists have given. Many have come back to us willing to share their experience and their interpretation with others. 18,000 people emanating from a small group like ours, I don't think we can be sneezed at. The next program we undertook, also with the government of India, we never give up. We went to the Ministry of Education. They had a new education policy out, which was to ask the university faculty to do more than just teach the curriculum. So we quickly jumped in and said, cancer fundamentals. I'll tell you our reason. They are the center from which the word can spread. And our aim is awareness. Without it, nothing can move. If you don't know what cancer is, you will sit back and wait for it to kill you. If you know what cancer is, you'll very well fight and try and overcome it. So each professor brings in 10 interns. So our pool is widening. This is our second year. We've made mistakes, no doubt, but we correct ourselves and move forward. The next thing that we did was just now. And Choti to idhar aa. Vaishali, Abhya, these two little girls manage the much maligned social media. And if you go to any of our social media sites, I'm very proud of both of them. But also, but also, very importantly, we have created an app which is called Rise Against Cancer. It is in 5 languages: Hindi, English, Marathi, Kannada, and Bengali. Would you like to say something in 2 quick words? 2 words, 2 sentences. Okay. All right. I have the last word yet.
Okay. So as we all know, our mobile phones are as essential habitual as food nowadays, and we are using them for ordering food, browsing beauty products, getting appointments, getting reports, and getting information as well. But when it comes to know about the medical info, we also, not the medical people, but general public, we also believe such fake websites or fake WhatsApp messages which are coming related to healthcare, eat this, drink this, you will secure yourself from cancer or any other disease. And once we told patients that don't trust those fake websites, then they asked then किस पे भरोसा करें? Is there any option? So as ICS launched their app Rise Against Cancer, in it's dedicated to empowering individual and community in the fight against cancer. And then we introduced this, and its quality already ma'am said it's available in 5 different languages. And right now we covered 4 cancers: oral, lung, cervical, and breast cancer. So all the information around these 4 topics you can check on the app. And not only about the doctors, we also have dietitian, physiotherapist, psychologist, financial literacy, and people who are talking about health insurance, why individual person need this, and what is the emergency fund, like every related topic. You can go on the app, and it's available right now on Google Play Store, and we are hoping it will be available on iOS as well, because as you all know, it's medical app and iOS has their own policy. So it's difficult to getting live our app on that platform. And
just open the app. It's free. Like all our services, everything that we offer is free of cost. Priya will be sitting here outside. Make use of the time to please talk to her and get what information that you need. So in short, we are doing a fair amount. I already mentioned that we have a medical assistance fund. We have in the past 20 years disbursed about 13 crores. Vaishali, am I right? Something like that. Yes. 13 or 14 crores. In fact, our headquarters was very surprised too. We are a small organization. We don't talk big. But when we talk, believe me, you can trust us. If we say we are going to support a patient, we will support that patient for the time that we have promised. We don't let them go. And we direct them to other people who can also help. We counsel people. I don't know where Indra just went, but she is our emotional support guide and tutor. She teaches us what to say, what not to say. As you in Batra know, there's my friend Usha, who has been with you for the last 30 years. I think she needs a big hand. So this is my last word, that please try to help us, because we are a voluntary organization. We don't have big budgets, but we have the will to make a difference in the life of a patient. And if that means reaching out to nurses, to young doctors, to family physicians, general practitioners, please help us to do it. This is the first of a series. We will be coming back. I don't know, Irfan, how often. We won't do it too often for you. But, well, we are hoping for 4 such things in a year. Okay? So please get your GPs and friends. I hope that it was a valuable enough session for you to recommend it for the future. Thank you very much.